Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Sarah Anderson. This episode features content regarding a call to action for increased awareness of hepatitis delta. During this podcast, Dr. Grace Wong, Professor of Medicine at the Chinese University of Hong Kong, and Dr. Ming-Lung Yu, Chair and Professor in the Hepatobiliary Division in the Department of Internal Medicine and Hepatitis Center at Kaohsiung Medical University, and visiting staff in the Hepatobiliary Division in the Department of Internal Medicine at Kaohsiung Medical University Hospital in Taiwan, discuss who is at risk for hepatitis delta and who should be screened so that they may be linked into care if they are hepatitis delta positive. For more information about Dr. Wong and Dr. Yu, and for a link to the full online educational program, please visit the link in the show notes for this episode. Now, let's get started and hear what Dr. Wong and Dr. Yu have to say about increased awareness of hepatitis delta.
Hello, everyone. I'm Grace Wong from the Chinese University of Hong Kong. I'm a hepatologist in Hong Kong.
Good day. I'm Ming-Lung Yu from Kaohsiung Medical University, Kaohsiung, Taiwan. I'm a hepatologist focusing on the viral hepatitis and also chronic liver diseases.
Professor, it's so nice to meet you here. And I know that in recent years, there have been quite a lot of advances in terms of hepatitis delta. So I really want to learn from you on this important topic.
Thank you. Actually, they do have a lot of progress in the management of hepatitis delta virus. But so far, the approved agents has only been approved in Europe, but not in the Asia Pacific and not in the North America. So there's still a lot of work we have to do.
Yeah, definitely. In fact, I'm always curious that chronic hepatitis B is so prevalent in our region, but kind of unexpected in Hong Kong. In fact, hepatitis delta is very kind of neglected because we don't even have very good tests to diagnose hepatitis delta. So how about the situation in Taiwan?
We have an encouraging program for the hepatitis delta because the National Health Insurance do reimburse the test of delta virus, the anti-HDV, but the National Health does not reimburse the testing of delta RNA. It's still a gap. The patient have to pay themselves. As Grace said, that is very important because in the general population, in our previous study, for patients with hepatitis B, there's just only around 2%, 1 to 2% of the HBV carrier had the anti-HBV seropositivity. So it's quite low in general population.
Yeah, in fact, in Hong Kong, we do not have very systematic review or screening for that. But I also look into our own data in Hong Kong over the last 20 years. We have kind of like maybe close to 10,000 patients with chronic hepatitis B with the anti-HDV serology tested. And among them, in fact, less than 100 were found to be positive. So which makes that, in fact, the prevalence of hepatitis delta infection among Hep B patients in Hong Kong would be very, very low. I would say that it's below 0.1%. So which makes this important disease quite, first, it's quite uncommon in Hong Kong, and also makes many doctors, even hepatologists, they would not think about that if some patients may have some risk factors. In fact, just a few months ago, I came across a patient who had a triple infection. He had hepatitis B, hepatitis C, and hepatitis delta because he is an intravenous drug user. So I guess this infection will still be found in some high-risk patients.
Yeah. But although the prevalence rates was low in the general population of HBV carrier, I would remind all of the not only the physician but also the HBV co-infected patients, because co-infected with the delta virus will increase not only the risk of end-stage liver disease, but also increase the risk of hepatocellular carcinoma, even for the patient who are underweight the anti-HBV oral nucleoside analog maintenance therapy. So I think it's very important that I would suggest every HBV carrier patients have to test the anti-HDV at least one times in their life.
Yeah, I think that would be a very good suggestion. Yeah, in fact, that's exactly what we observe in our patient, even though we only have a very small cohort, less than 100 patients with positivity in anti-HDV antibody. But we also find that the risk of having HCC and also all those cirrhotic complications would be significantly increased. But I think the challenging point is we are kind of taking care of so many patients with chronic hepatitis B. So, for example, in Hong Kong, the prevalence is still around 6% in adult populations, which means that we still have at least 500,000 of such patients with chronic hepatitis B. So I just wonder whether we should really screen all of them, or you would suggest maybe at first we can screen some patients with risk factors first. How about the plan in Taiwan?
So far, there are no recommendation from the liver society,
Right.
but because in our recent study, we observed if for patient with active chronic HBV infection, the anti-HDV penetrance rate was around 2.3%, and HDV viremia rate was around 1%. Even such a small population, they are at a very high risk of HCC. So I would suggest at least chronic HBV infected patients who are going to receive the nucleoside analog therapy. It means that the patient have active inflammation of the liver. They need to test for anti-HDV at least once at their lifetime.
Right.
And also, as Chris say, you are verified, the other population are at a very high risk of HDV. The first one is the person who injected drug.
Right.
Because we from around 15 years ago, we started to evaluate the anti-HDV penetrance rate in this special population. The anti-D seropositivity was very high. Around 40% of the HBV carrier were possible anti-HDV in PWID population around 15 years ago. Recently, the penetrance rate decreased a little bit from 40% to 25%, but still very high. So I would suggest patients with experience of PWID or currently with PWID have to check the anti-D because of the very high penetrance rate. Another population is the social work person. Yeah, is also at the risk of anti-D.
Yeah, I think that's a very wise move to really target the screening maybe at the very beginning for those with risk factors. Yeah, I also want to discuss a little bit about the treatment, even though now in Asia, we do not have the new drugs at this moment. But would you think that maybe some of these patients you may consider to use maybe pegylated interferon, because that can help both the viruses, both the hepatitis B as well as the Delta virus? Do you have some experience on this aspect?
Yeah, actually, because the Taiwan health insurance does not reimburse the PEG interferon in the treatment of HDV, but we do have a few cases. They have active HBV inflammation and eligible for the PEG interferon therapy around 10 years ago. We did observe dramatic decline of the not only the HBV DNA, but also the HDV RNA. Unfortunately, after stopping the PEG interferon, most of the patients have HDV RNA relapsed. So I think we need a more powerful regimen, whatever the engine inhibitor or combination of the engine inhibitor plus the PEG interferon. Yeah, we needed the new regimen to treat our patient, and so I think they are not that can advise us how long of the anti-HDV regimens should we have for our patient to prevent the biological relapse.
I agree. Yeah, this is a very important question. In fact, I also had some experience myself in the old days using pegylated interferon. In fact, I have a few patients from Mongolia. They have very active hepatitis B and also Delta. And for those patients, we put them on pegylated interferon as well as the oral NUT combination therapy for up to like 2 years. In fact, usually after the initial months, there are like the ALT would be normalized, HDNA level, HDV RNA level would decrease. But I agree with you that if we stop like just around a year, usually there will be quite a lot of relapse of the Delta virus. So some patients will prolong their treatment. But I fully agree with you that, in fact, the exact treatment duration is to be defined. I think some studies are not in the recent years showing that if you just treat the patient for a year or so, many patients will relapse. So now many studies will keep on like 2 years or even prolonged maintenance therapy. So I will have to say that this is a very challenging infection to clear. But I'm so happy, so looking forward to the new drugs that now is available in Europe, in the West. I hope that we will get access to these drugs in Asia very soon. Yeah.
Yes, I hope so. Before the availability of the anti-HDV regimen, I think we have to advise not only the patient, but also the physician to increase the disease awareness. Also, although it's a very small population, but it do have a lot of long-term complication if the patient get the HDV and HBV.
Yeah, I fully agree with that. And I really hope that, because in Hong Kong, we don't even have the HDV RNA assay in our public lab. We have to send the samples to some private lab. I also hope that our government can increase their accessibility to the assays so that we can really screen our patients and also to measure the viral load of the Delta virus if we really suspect active viremia.
Yeah, sure. So, Grace, would you recommend to have a more closely monitoring for the patient with HBV and HDV co-infection?
I would say that at least in Hong Kong, because the prevalence is still not too high, so I would prefer to have like more targeted screening, like what you mentioned just now, some important risk factors. We may consider to screen those subjects like those pivot and sexual workers and other risk factors. And probably for those who have been on very potent antiviral drugs with good suppression of the HBV DNA, but somehow their ALT remains unstable, fluctuating. I think these patients we may also consider to test for anti-HDV first. And if it is positive, then we should also check the HDV RNA.
Well, yes, perfect, exactly. Yeah. We also observe the patient who under maintenance nucleoside analog for HBV, but still have a elevated ALT level. And I think the HDV co-infection play an important role in this clinical issue.
Yeah, fully agree with that. Yeah. That's all I would like to share. So, Professor Yu, do you have any other topics or you would like to share?
Oh, yeah. The topic here is that we have to increase the awareness to test the patient with anti-D, at least for the patient at high risk behavior. And then if the patient have HBV co-infections, to at least to treat the HBV inflammation and closely monitoring the patients with liver function test, ultrasound sonography to early detect the hepatocellular carcinoma, if any. And we are very eager waiting for the new anti-HDV regimen for this patient population.
Yeah, really looking forward to that. Okay. Thank you so much for your expert opinion on this.
Thank you very much. It's very happy to have you to join this discussion.
Thank you very much to Dr. Wong and Dr. Yu, and thank you to our listeners for joining in. As a reminder, to view the full Don't Delay with Delta program on the Clinical Care Options website, click on the link in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.